You may begin.
Okay, welcome everybody. Today I'm going to talk about renal tubular acidosis. And in addition to the acid-base abnormalities, it's important to realize that there are a number of other electrolyte abnormalities and a whole variety of clinical syndromes. In particular, today I'm going to be talking about the hypokalemic disorders. So we divide up renal tubular acidosis into types, and it can be done as far as types, or you can do it as far as what parts of the nephron. More logical are the parts of the nephron. We divide it up simplistically into proximal and distal. The types are a little more complicated because they don't make a lot of sense, and it's more historic based on the work of Morris and Sebastian in the late 60s and 70s. Tony Sebastian was actually a fellow when he contributed to the typing of the disorders. So we have proximal, not called type 1, like you'd think it would be if you were just going in order down the nephron, but it's called type 2. And that's just something you have to memorize. Distal is type 1. That refers to the hypokalemic disorders where the more distal part of the nephron is affected. I'll skip to type 4, which is also a distal form of renal tubular acidosis, but unlike the type 1, it's associated with hyperkalemia. So it's the potassium that distinguishes the type 1 and the type 4, not the part of the nephron. And type 3 is a combination of type 1 and type 2, where both parts of the nephron are affected. In all these disorders, you can have, like everything in medicine, genetic causes and acquired causes. And for the hypokalemic disorders that I'll be discussing today, we'll go through those with some examples. And I'll be particularly talking about type 2 and type 1 today. As far as the literature, it was really in 1935 that the entity first appeared, but there was no term renal tubular acidosis. Actually, what was described was what was called calcium infarction of the kidneys in infants. The word infarction was used, but really this was calcification of the renal parenchyma, or what we would call nephrocalcinosis today. There was no chemistry of the blood, acid base or electrolyte abnormalities associated with this. It was more a pathologic finding that there were these kidneys in infants that appeared to be calcified. But in retrospect, these were probably some of the patients were patients with nephrocalcinosis and renal tubular acidosis. And it was not until 1951 that the term renal tubular acidosis first appeared in the literature. It was a paper in the American Journal of Medicine, and these patients were described who had bone abnormalities also. We now know today that this is a normal or non-anion gap type metabolic acidosis. There are abnormalities either in renal bicarbonate absorption or renal bicarbonate generation, which I'll distinguish during the talk. There are also associated changes in renal ammonia handling, calcium transport in the nephron, potassium transport, and also water homeostasis. And then outside the kidney, there are extrarenal manifestations that are helpful because if you know these manifestations, they can help you define the disease entity that is actually causing the renal tubular acidosis. Because remember, renal tubular acidosis is an end result. It's not a clinical diagnosis per se, sufficient by itself. In addition to saying someone has renal tubular acidosis, you also have to then go further and think of the clinical cause. So before we get into the clinical phenomenology, I'm going to back up and just talk a little bit about some physiology in the nephron. And to understand what's going on in renal tubular acidosis, you have to understand how bicarbonate is handled. So as most of you know, bicarbonate is freely filtered. It gets through the glomerulus. And obviously, if nothing happened after that, we would be excreting all this bicarbonate in the urine. And it turns out when you do the math, and the math is simply taking the plasma bicarbonate concentration of 25 millimolar and then multiplying that by the GFR, the amount of water that we filter through all our glomeruli, which is about 150 to 180 liters per day. It turns out that you're filtering about 4.5 moles of bicarbonate a day. And that's roughly equal to all the bicarbonate in a box of Arm & Hammer baking soda that you have in your kitchens. So if we did nothing as far as after the glomerulus, we'd be excreting about a box of Arm & Hammer baking soda in our urine every day. And obviously our plasma bicarbonate would drop very quickly and become severely acidemic. So we know that doesn't happen. So without knowing the mechanism, we know a priori that the bicarbonate must be absorbed. And it would take about 4 hours if we didn't reclaim this bicarbonate before our blood bicarbonate would go from 25 to 0, which is obviously not compatible with life. So what evolved in all mammals is what we call transport machinery that allows the bicarbonate to go from the luminal side, the glomerular or urine side, to the blood side. And the first thing to understand is there's no direct reclamation of bicarbonate of great physiologic importance. It's an indirect mechanism. And so what evolved was to have two proteins on the what we call the apical membrane, or the luminal side, or the urine side of the cell that transport protons into the urine. One of the proteins is called NHE3. It's one of the NHE stands for sodium hydrogen exchanger. There are a number of these genes, but it's this particular one that is in all mammalian proximal tubule cells, and it takes up one sodium ion into the cell in exchange for a proton. And remember, it's driven by the sodium gradient, because the sodium here is 140 millimoles per liter approximately, but in the cell, it's only about 20 millimoles per liter. The normal sodium in a cell is much lower. So there's a huge sodium gradient. Plus the pH in a cell is not 7.4, it's about 7.1 or 7.2. So the proton gradient is to go out, remember, because this is around 7.4 on the lumen. So this is constantly taking a sodium in and shooting a proton out. The other mechanism for getting protons in the lumen is on a protein complex. It's not one protein that we call the vacuole or proton pump, and this requires ATP. NHE3 does not use ATP. And then when the protons get in the lumen, they bind bicarbonate, and they ultimately form water and carbon dioxide. Well, the water and the carbon dioxide go back into the cell because we've created a slight concentration gradient now across this apical membrane, and they actually don't cross the lipid bilayer predominantly. They go through a protein called aquaporin 1 back into the cell. And then once they're in the cell, the reverse process occurs where we regenerate the proton, and I don't have depicted here, we generate bicarbonate, but we also generate carbonate. And the reason I put that there, you'll see in a minute. So you can think of the protons as actually just recycling around the apical membrane. These chemical processes are catalyzed by carbonic anhydrase. They'll occur without it. It just carbonic anhydrase speeds them up. So carbonic anhydrase 2 is a cytoplasmic carbonic anhydrase, which speeds up this reaction. And carbonic anhydrase 4 is actually attached to the apical membrane. It's called a GPI anchored protein. And it actually the catalytic center is sitting in the solution of the urine or the glomerular filtrate, and it catalyzes this reaction. So the carbonate is made, and it actually leaves the tubule on a protein called NBCE1A. This protein transports a sodium ion out of the cell and a carbonate out of the cell. You can see immediately that these are not the same charge. So this protein actually is called an electrogenic transporter. It's not a channel. The channel only transports one ion. This is called an electrogenic transporter or co-transporter because it's co-transporting two ions, but it actually carries a charge of -1 because carbonate has a charge of 2-, where sodium only has a charge of +1. There are other entities on the so-called basolateral or blood side of the cell, and they're important because they generate this electrical potential across the basolateral membrane. So there's actually a voltage across this membrane that's around 50 millivolts more negative inside than outside. And it's actually this voltage which drives the transport of sodium and carbonate out of the cell. Because if you think of it, the chemical gradients are to take sodium into the cell, and the carbonate concentration is actually greater in blood than in the cell. So if there was no electrical driving force, sodium and carbonate would actually never be able to get into the blood. They'd be leaving into the cell. But in all mammals, there's this electrical voltage on the basolateral membrane generated by the sodium pump and this potassium channel, which I'll talk a little bit more later, that create this electrical potential to drive the sodium and the carbonate out of the cell. And that's how bicarbonate gets from this side to the blood side. And that's why one of the reasons our bicarbonate stays at 25. Now, there's a second process that we have to keep the bicarbonate at 25. This is as follows. Every day, there's protons added to our blood from the diet we eat. And there's around 50 milliequivalents of protons added daily. They come out of the liver into the inferior vena cava, and they combine with bicarbonate and create carbon dioxide and water. The carbon dioxide we excrete, but if nothing else happened, we'd be lowering our bicarbonate every day. It's like having an IV with hydrochloric or sulfuric acid in it. So every day the bicarbonate would be lowering, and it would take a number of days till the bicarbonate went to 0, around 14 days. Now, it's important to realize that the proton load from our diet depends on the type of food. So people have come up with this kind of chart where we have base-forming foods, or you can think of it as bicarbonate-forming foods or acid-forming foods. Not all food releases protons. So the food that tends to release the most protons are egg yolks and cheeses, whereas spinach and raisins are the most bicarbonate or base-forming foods. So it depends what we eat. And obviously, it's a combination of everything that determines the net proton load. Now, it turns out historically that this changed. Originally, humans were carnivores, and about 10,000 years ago, we figured out how to cultivate fruits and vegetables, and the proton load in the diet changed. It turns out that when you have an animal to plant ratio in your diet of about 60%, your so-called net acid production, and you can think of that as the net proton load, is 0. So as you increase the animal to plant ratio in your diet above 60%, you make more and more and more protons. And there's a whole literature on the significance of that, how it affects your bones, and the effect of that on the elderly, which I won't get into today. But just know that the average North American eats quite a lot of meat, and the ratio of animals to plants is around 80%, 85%. So the proton load works out to about 50 milliequivalents per day. So the average person puts in about 50 milliequivalents per day. And as I said, that binds to bicarbonate and would tend to lower it. But something happens, and that is we have kidneys. And the normal kidney actually generates around 50 milliequivalents of bicarbonate a day to match this hepatic proton load. Now, it's very important to realize this has nothing to do with the bicarbonate that was reclaimed from the glomerular filtrate that I just talked about. This is a separate phenomenon. And this bicarbonate is generated beyond the bicarbonate that was reclaimed in the glomerular filtrate via the transport processes I just showed. And what this does is it matches the proton load such that we end up creating carbon dioxide, and the carbon dioxide we just excrete. So this process, this second process, must occur in all of us to also keep our bicarbonate concentration in our blood from falling. If, for instance, we can't generate the 50 milliequivalents of bicarbonate, our bicarbonate would start to fall. And that's actually the mechanism of why patients with CKD and ESRD have a metabolic acidosis. It's because they can't generate bicarbonate sufficiently to match the daily hepatic proton load. So how do we generate the bicarbonate? Well, it turns out most of the bicarbonate is generated from this substance called alpha-ketoglutarate, which is depicted in short form here. And it comes from the amino acid glutamine. Now, glutamine gets into the proximal tubule across the apical membrane, and also some of it gets absorbed into the proximal tubule via the basolateral membrane. But be that as it may, the alpha-ketoglutarate is a byproduct of the glutamine. And in the Krebs cycle, the alpha-ketoglutarate is turned into 2 bicarbonate ions. So in our mitochondria, the alpha-ketoglutarate generates 2 bicarbonate ions, which then gets absorbed on NBCE1A, the protein I showed you before, into the renal vein. Now, it turns out in the process of creating bicarbonate or a metabolism of alpha-ketoglutarate, this other substance is also made. Ammonium is also made as a byproduct of the reactions that metabolize alpha-ketoglutarate. Now, that's not a good thing. And the reason is, if the ammonia that was derived from glutamine were transferred to the renal vein with the bicarbonate that was produced, the bicarbonate would be consumed in the urea cycle. So the bicarbonate would not be free to match your daily hepatic proton load. Instead, if there's ammonia that's also coming out of the cell with bicarbonate, the ammonia and bicarbonate would be consumed in the urea cycle in the generation of urea. Because remember, urea is formed from 2 ammonium and 2 bicarbonate ions. And so if you have bicarbonate coming to the liver stoichiometrically with an equal amount of ammonium, you're not going to have the bicarbonate free in solution to match the daily hepatic proton load. Instead, it'll be wasted in the generation of urea, which you'll just excrete in your urine. So it's very important. And then you'll just have turned glutamine into urea when you think about it. And you'll have not done nothing for your acid-base needs. So it's very important that the ammonia that comes out of the cell back into the blood just doesn't stay in the blood. And it turns out that we have this concept called renal ammonium partitioning, where the ammonia that comes out of the proximal tubule cell doesn't stay in the cell, doesn't stay in the blood, where it'll be free to consume bicarbonate in the liver. Instead, we get rid of that ammonia. Now, we don't get rid of all of it. We get rid of 60% of it, which is a help, because the 60% that we got rid of will free up 60% of that bicarbonate that was generated from glutamine to match your daily hepatic proton load. Some of it is wasted in the formation of urea. The 40% that doesn't get excreted uses up that component of bicarbonate to make urea. And then in a certain sense, that's futile. The ammonia gets into the urine via a number of complex transport processes, which I won't have time to talk about today. But in the final step of the transport mechanisms involved in the urine, it gets into the collecting duct via proteins that are called RhCG and RhBG. These are, you might have heard of these in the red cell, where the baby can get Rh disease. Well, these Rh proteins are actually NH3 transporting proteins. There's no ATP involved. They just, NH3 permeates across these proteins. That's how ammonia gets into across the collecting duct, plasma membrane. In the lumen of the cell, or in the lumen of the tubule, excuse me, you need to create an NH3 gradient for NH3 to cross from the outside into the lumen. So the NH3 in the lumen of the tubule is constantly being decreased by its conversion to NH4+, because we have protons via proton ATPases that acidify the lumen of the tubule that's constantly decreasing the NH3 concentration in the lumen here by turning it into NH4+, thereby creating a concentration gradient for NH3 to continuously enter from the outside of the, from the interstitium, from the outside of the tubule. So the bottom line here is we normally have this partitioning where 60% of the ammonia we are able to get rid of, freeing up that component of bicarbonate that can now match your daily hepatic proton load. The other 40% is wasted in the creation of urea. Now, the other way we create new bicarbonate to match the daily hepatic proton load is another category called TA excretion, or titratable acid excretion. 60% of this occurs in the proximal tubule and 40% in the collecting duct. You'll see in a lot of textbooks or papers that this is a distal or collecting duct phenomenon, but it's not. When you do the math, it turns out that the majority of it is actually occurring in the proximal tubule lumen. And what happens is the cells, whether they're proximal tubule cells or collecting duct cells, secrete protons and convert HPO4 to H2PO4 2-. And when that's done, it turns out that a bicarbonate ion is generated in the cell, which leaves the cell to the blood side. So every time we secrete a proton and create H2PO4 2-, we generate a bicarbonate ion, which then can go into the blood also. So this is where the rest of the new bicarbonate generation is occurring to match the daily hepatic proton load from our diet. So let's now go to some clinical cases. This is a 57-year-old female who was blind, had bilateral glaucoma and bilateral cataracts, and she was short. She had corneal opacities, abnormal teeth, and intellectual disability. This was her eye showing band keratopathy. This was her teeth that looked abnormal. And she had opacities in the brain, in the basal ganglia. So once you're more familiar with the clinical manifestations and potentially for the renal boards, there's only one entity that can cause this. So you should already, once you're more familiar with it, be thinking of what the diagnosis is. These were the blood chemistries. Of note, the potassium was potentially on the lowish side, although not very clear. But most clear was the pH was 7.27, the bicarbonate 12, calculated bicarbonate 12, and the PCO2 was 27. Of note, the urine pH was acidic, and the fractional excretion of bicarbonate, which is the amount of bicarbonate excreted in the urine divided by the filtered load, was 30%. Normally, that should be under 1%. We don't excrete our filtered load of bicarbonate, we absorb the majority of it. So to be excreting this much of the filter load of bicarbonate tells you that there's something wrong with the proximal tubule of the kidney. And we calculate that, remember, by taking the urine bicarbonate times the plasma creatinine over the plasma bicarbonate times the urine creatinine, just like we calculate the fractional excretion of anything. So it doesn't matter what the substance is, the calculation's the same. Well, this patient had isolated proximal renal tubular acidosis, meaning that this was the only phenomenology of abnormality in the proximal tubule. There weren't any other transport abnormalities where we would call that Fanconi syndrome. This was just bicarbonate reclamation. When we have isolated proximal RTA, we think of two genetic causes predominantly. The majority are autosomal recessive and are so far have a mutation in NBCE1A, that basolateral protein that I talked to you about that absorbs carbonate across the basolateral membrane as sodium carbonate. There are a few cases reported that are autosomal dominant. People have looked but have not found the protein involved yet. And this is the part of the nephron that we're talking about, the proximal tubule. So again, getting back to the transport machinery, there's nothing wrong with the apical membrane, but here's where the problem is. NBC1A is not transporting sodium carbonate across the basolateral membrane. And this protein is now known. Our lab actually showed its subatomic structure a few years ago, but it has 14 transmembrane regions, which are the parts crisscrossing the plasma membrane, and it weaves, like all membrane proteins do, in and out of the plasma membrane. And the red shows the where the mutations are. They've been described throughout the transporter, and there are some mutations also in the C-terminal membrane part of the transporter here. This is the cytoplasm, or inside the cell. This is outside the cell. And the N-terminus here, there are some transport abnormality mutations that have been found. And most of them are missense, where you have an amino acid substitution which stops the function. Some are nonsense, which means that you have an amino acid substitution that stops the creation of the entire protein. So there's one here where you only have 28 amino acids made, and then the protein just stops being made. So obviously that's going to be a major problem. And this is what the transporter actually looks like that we published. This gray area is actually a belt of detergent that was used to isolate the transporter. And it's a dimer. It's actually two separate monomers that are coupled to each other. And the transport actually occurs roughly in these regions of the protein. This is an interesting mutation. So when we study this protein, we do something called patch clamping, where we can look at the current carried by the transporter. And normally, when you study it without bicarbonate, you get a current like this, sort of the control current. And then when you add a bicarbonate solution to the cell, you get this kind of change, going from the open circles to the closed circles. And this is due to an inward current going into the cell. This is what you would normally see in the wild type protein. In the red here is what you see with this one particular mutation, this threonine 485 serine mutation. You don't get any current at all. And it turns out that you lose the electrogenicity of the current. Now, this transporter actually still transports sodium bicarbonate, but it loses the ability to do it electrogenically. It actually converts from carbonate to bicarbonate transport. And because bicarbonate has a charge of -1, it becomes what we call an electroneutral transporter. But because of its inability to see the basolateral membrane potential, it actually takes sodium and bicarbonate into the cell, where these chemical gradients drive it in the wrong direction. So these patients just cannot absorb sodium carbonate into their blood. So it's one of the interesting mutations. These patients also have extrarenal manifestations, including the brain, where they have intellectual disability and migraine headaches. These aren't well understood. It's just more phenomenology. In the eye, they have corneal and lens opacities, and they also have glaucoma. Their intraocular pressure goes up. And they also have abnormal teeth formation. We've shown in knockout mice that NBCE1 is very important in mammals for enamel formation. So if you don't have it, you just don't create, you don't create a normal ameloblasts that have enamel on them. The eye is interesting because when you think about it, and this is actually data from measurements, the tear film pH changes dynamically whether you open or close your eyes. When you close your eyes, the pH actually drops. And when you open your eyes, the pH actually goes up. And this is because when you close your eyes, carbon dioxide from inside of your eye cannot leave. And so you can think of it like almost a respiratory acidosis. When you open your eye, all the CO2 leaves and you alkalinize the outside solution. So the pH of the tear film is constantly changing on our eyes. Now, we have this problem shown here pictorially of carbon dioxide. This is the inside of the eye. This is the outside. These are supposed to be the eyelashes. This is the cornea here. So carbon dioxide, with the eye open, the carbon dioxide is all leaving, and the PCO2 in the tear film here can go to 0 very quickly. And that's going to alkalinize this solution. But we have NBCE1 here in these cells, the endothelial cells on the inside of the cornea that send sodium bicarbonate out of the cornea and tend to acidify it. This counteracts this alkalinizing process, and that's very important because without NBC1A, we just have alkalinization occurring excessively, and that causes calcium phosphate to precipitate, and that's the cause of the band keratopathy. So remember, calcium phosphate solubility is very pH dependent, and if you go a little above 7.4, it comes out of solution. And so in the absence of NBCE1 in these patients, you have excessive alkalinization of the front of the cornea because of the abnormal pH regulation of the tear film. And one of the therapies is to give the patients EDTA eye drops. EDTA is a calcium chelator, and it helps get rid of some of this abnormal calcification. So in addition to NBC1A, other abnormalities have been described, not in humans, but in mice. They've knocked out NHE3, and these mice get a mild proximal renal tubular acidosis, which initially was not well understood because NHE3 is felt to be by far the most important process for sending protons into the lumen and absorbing bicarbonate. But the patients have proton secretion still remaining via the vacuolar proton pump. And so that may be what's compensating, but it's still not well understood why the mice don't have more of a severe proximal RTA. There are patients with mutations in carbonic anhydrase 2, and they get proximal RTA. They also get distal RTA because it's important in collecting duct proton secretion. And so they get actually a type 3 renal tubular acidosis. Then there are mice where, not humans, where TAS2, which is the name of the potassium channel here, has been knocked out. And these patients and these mice have normal NBCE1A, but you perturb significantly the basolateral membrane voltage here when you do that. And so even though NBCE1A is intact and could potentially see the potential is gone to a large extent. And so you've lost the so-called electrical driving force for driving sodium carbonate out of the cell in these mice. Now, in addition to the genetic causes that we discussed affecting NBC1A, there are other genetic causes with additional transport defects, but they tend to cause a Fanconi syndrome where you have abnormal phosphate transport, potentially uric acid transport, amino acid transport, and it doesn't have to be all of those. They can be, one can be present, the other's absent. But the bottom line is there's more than just a bicarbonate reclamation defect. And these are some of the diseases that are involved, but they all have in common an abnormality in bicarbonate transport. In most of these, the abnormality in bicarbonate transport at the molecular level has not been determined. We don't know which of the transport machinery that I just described is affected. Now, what is the mechanism then of the metabolic acidosis in proximal RTA? Well, as we described, it is a defect in proximal tubule bicarbonate absorption, or it's also called reclamation. And we diagnose this by having a fractional excretion of bicarbonate over 15 to 20%. Now, the reason we say over 15 to 20% is because the proximal tubule absorbs about 80% of the bicarbonate. So if our fractional excretion of bicarbonate is over 15 to 20%, we know a priori that we must have, at least in part, a proximal tubule abnormality. If the fractional excretion is 5 or 10%, we know it's abnormal. We know somewhere in the nephron there's a problem, but we can't say with certitude that it's the proximal tubule, because you could have a 5% abnormality in your thick ascending limb or a 5% abnormality in your collecting duct. Only if it's over 15 to 20% can we say with certitude that at least part of that 15-20% must be proximal tubular in origin. So we talked about some of the causes. As far as the approach, if there's a drug involved, which we didn't talk about yet, there are drugs that can affect the proximal tubule bicarbonate reclamation machinery. Again, not well understood at the molecular level, such as ifosfamide, the chemotherapeutic agent, or topiramate. You remove those, obviously, it'll be reversible. And again, we've got, bicarbonate coming into the system and bicarbonate leaving excessively into the urine. So we replace the bicarbonate simplistically, and we give bicarbonate back. In a child, as depicted here, we need more just because they're growing and they tend to need more than the adults. And we don't give it in the form of bicarbonate because it tends to cause burping when the proton in the stomach combines with bicarbonate. It creates carbon dioxide. So we give it in the form of citrate. And citrate is nice because when it gets into the body, it's converted into bicarbonate, just like lactate is in our peritoneal dialysate, just like acetate is in our TPN solutions. All these organic anions with carboxyl groups are converted into bicarbonate in the body. And so you give this and you don't get the CO2 creation in the stomach that you get with bicarbonate. And we give sodium citrate. Sometimes we'll give K citrate, depending on the patient's potassium. Now, in addition to the bicarbonate loss, which is sort of the intuitive and simplistic easy answer for why someone with proximal RTA has a metabolic acidosis, there's another phenomenon which is not well recognized, and that is there's also a problem generating new bicarbonate. Now, this is data from patients, some of the patients that had the autosomal dominant proximal RTA. If you look at their baseline compared to the normals, the urine ammonia in the proximal RTA patients is roughly equal to the controls, and that should not be. If they have abnormal bicarbonate generation and transporting machinery for ammonia in the nephron, their urine ammonia should be sky high, just like it is for anyone who's got a metabolic acidosis, whether it's renal or extrarenal. The kidney generates more ammonia and more bicarbonate to match the proton load, and more ammonia is made as a byproduct, and you see it in the urine. These patients have the same amount of ammonia, and since the ammonia is being made in the same process from alpha-ketoglutarate that generates bicarbonate, we know indirectly that the bicarbonate generation rate must have been lower also. And when you acid load these patients, the urine pH falls. It can fall. They have proximal RTA. There's nothing wrong with the collecting duct, but the urine ammonia doesn't go up like it does in a normal person. You can see here in the green, it's far below that. So these patients have an abnormality in renal ammonia excretion, and by inference, new renal bicarbonate generation. So their metabolic acidosis really has two mechanisms. One, the simplistic bicarbonate loss, which everyone is aware of. But secondly, you have to be aware that they also have a bicarbonate generating problem. Now, why that is, people hypothesize, well, maybe their proximal tubule pH is too high. There's something indirectly affecting the glutamine to 2-bicarbonate reaction here, possibly due, as I said, to abnormal intracellular pH, but no one really knows. And this has been replicated in the NBC-E1A knockout mouse, where if you look at the ammonia excretion in the wild type, it far exceeds what the NBC-E1A knockout mouse has in the urine. And again, it's been hypothesized that, well, maybe there's something that's abnormal about the intracellular pH in these proximal tubules, but that will contribute to the metabolic acidosis also. Okay, let's go to another patient. This is a 3-year-old female with decreased hearing and polyuria, 18 percentile for height, again, short, severe bilateral sensory neural hearing loss, and rickets. And again, once you get more familiar with this, this really will hone you down to what the molecular cause is. As far as the blood, the patient was hypokalemic, pH 728, calculated bicarbonate 11 with a PCO2 of 24. This time the urine pH was not low, it was on the alkaline side. And the patient had a high calcium to creatinine ratio of 1.2, so the patient was hypercalciuric. And as you see here, there was nephrocalcinosis. So this patient has hypokalemic distal RTA, and the abnormality here is in a cell called the intercalated cell, the type A intercalated cell, because there's at least two types, type A and B. There's actually a third type. The type A cell is the cell that secretes protons, and we can recognize that this is actually inside the collecting duct lumen, a scanning EM, and you can see very beautifully here these intercalated cells which have these worm-like structures on the luminal side that are called microplici. This is a principal cell, and it can be recognized because it has one cilium. This is the cell that absorbs sodium and secretes potassium and is involved in Little syndrome and some of the hyperkalemic distal RTA. This cell is the cell that secretes protons and is responsible for the final acidification of our urine. And it's situated here in the collecting duct. So this is now a cell model of the machinery in this cell, and it's different significantly from the proximal tubule cell. It has a proton atpase, the same protein we talked about before, and this is protein primarily responsible for secreting protons and acidifying the final urine. It also has another protein called KH-ATPase, which is felt to play a minor role in acidification of the lumen. The proton again comes from water and carbon dioxide, catalyzed by carbonic anhydrase 2, and generates bicarbonate. Now the bicarbonate leaves the cell on another protein, not NBCE1A, but another protein called AE1, which doesn't transport bicarbonate, but transports bicarbonate in exchange for chloride, 1-to-1. So it's an electroneutral exchanger. It's not a channel. There's another protein here which transports chloride called ClCKB, and the chloride that comes in actually can leave here. So the chloride sort of recycles. This protein also, you might remember, is also involved in the thick ascending limb because when it's mutated, it's one of the causes of Bartter syndrome. So that's the machinery here. AE1, just to put it in context, is the same protein as BAN3, which makes up 60% of the protein in a red cell membrane. It's the predominant protein in a red cell that's responsible for helping us get carbon dioxide from our cells to the lungs for excretion. But it's also important here for getting bicarbonate out of the cell into the blood. So the problem with this patient is in this protein complex. Remember, it's not one protein, as I'll show in a minute, the proton ATPase. This is what it actually looks like. It's made up of a number of different proteins. This is the cell side. This is the blood side. This would be the cell membrane. These actually stick out of the cell membrane or the lipid bilayer a little bit. They're still in the lipid bilayer. And this is the machinery that transports the proton into the cell. It actually, if you look at it, it actually looks like an electric motor, where this is actually spinning around the stalk here, sending protons into the cytoplasm. It looks at the substructural level like a human engineer designed it. It's quite a remarkable structure if you want to Google it. But at any rate, these subunits here are called the B1 or A subunit. And it's the B1 subunit here, which is mutated in this patient. And these patients have hypokalemic distal RTA, an elevated urine pH, nephrocalcinosis, hypercalciuria, calcium phosphate stones, a low urine citrate, and they have decreased NH4+ in the urine. Not because of a problem generating the ammonia from glutamine, but as we'll see, a problem with ammonia partitioning. There are other patients that also have this A4 subunit mutated, and they can have the same phenomenology. These patients also have rickets or osteomalacia, and they have sensory neural hearing abnormalities. This is because the vacuolar proton pump is actually anatomically involved with the transduction of impulses that come in our ear, sound waves, to creating a signal in the auditory nerve. And so if you don't acidify the cochlea normally, you can't hear. And I don't have time to get into that today, but just know that it's not only important for urine acidification, it's important for hearing also. So that's just the A4 subunit, which can also be involved. Now, there are other patients with hypokalemic distal RTA that have a normal vacuole or proton pump, but have mutations in A1. And this can be either recessive or dominant. The recessive patients tend to be in the tropics, not North America. It's more prevalent there, and the phenomenology is more severe. And by severe, I'm talking about the age of diagnosis is younger. They have a more severe metabolic acidosis. They have more severe hypokalemia. Because, as I mentioned, this protein is also in red cells, they get red cell morphologic changes. They have nephrocalcinosis also, and they can get bone abnormalities also. When it's in the dominant form, it tends to be more in North America, involving Caucasians. It's quite rare, and the phenotype is less severe. There are other mouse models of distal RTA that haven't been shown to be in humans. In addition to what I showed, there's also a potassium chloride cotransporter here. There's a number of them. This one's called KCC4. When it's mutated, the mice get distal RTA and hypokalemia. And there's another transporter, SLC26A7. It also, in the mouse, has been, when it's knocked out, shown to be associated with distal RTA. And it turns out that there's a whole bunch of other proteins in the mouse. Some of these now have been shown to be in the human also, and they have very interesting and different phenomenologies. When this FOXI1 is mutated, you only have one type of collecting duct cell. You don't have principal and intercalated cells, and they're missing a lot of different proteins in the cell. The Henson knockout mouse actually is missing type A intercalated cells altogether. So they have different and interesting phenomenology that's been described over the years. Now let's get back to the whole body acid-base balance, and we'll need to think of this again in order to understand why patients with distal RTA get metabolic acidosis, because we haven't talked about that yet. So remember, we generate typically 50 milliequivalents of protons. Our kidney is generating 50 milliequivalents of bicarbonate, derived predominantly from alpha-ketoglutarate. The two of them unite, we create carbon dioxide, which we excrete. Now, there's this phenomenon called incomplete distal RTA. These patients have a normal acid-base status, normal bicarbonate, normal pH, but they tend to have a low urine citrate as a clue. They have nephrocalcinosis as a clue. They have calcium phosphate stones, and they have hypercalciuria. And when it was found, actually by Wrong, who first published it in 1959, that when you acid load these patients as a stress test, since normally they don't have any acid-base abnormalities, it found that the urine pH stays above 5.3. And that was really the only clue that there's something going on in the acid-base sense. Now it's known that we can divide these patients up further in a more complex way. So when you think of incomplete distal RTA, which again are patients with normal acid-base status. So when you have someone with normal acid-base status, remember, you're not exonerating their collecting duct acidification processes. They still may have an abnormality, and the only way you can see that is to stress the system. When you give these patients ammonium chloride, what you find is that there are some patients where the urine pH stays above 5.3, but there are other patients where the urine pH can go below 5.3. Now you would say, well, there's nothing wrong with them. But if you look further at what their ammonia excretion rate is to subdivide these patients up further, that's how they're now further categorized. We don't have types for these yet. Just know for your exam that incomplete distal RTA now is not felt to be one disease. So there are patients that have a normal acid-base status in their blood, normal acidification capability when you stress the system with ammonium chloride, but some of these patients are not able to increase ammonia normally in the urine as occurs in a typical patient. Then there are these patients that can't acidify the urine normally, can't increase the urine ammonia as you would expect, but there's a subgroup where the urine ammonia excretion does go up normally. So again, just remember that the diagnosis of incomplete distal RTA is not simplistically that patients have normal acid-base status, you give them ammonium chloride and they can't acidify the urine. That's sort of more historic now. They're now divided up into these different categories based on whether they can acidify the urine or not and what their urine ammonia excretion rate is. It's felt that some of these patients might have abnormalities in the Rh proteins. And so even though their vacuolar proton pump and AE1 are normal, they can acidify the urine, they can't get ammonia into the urine normally. It can't permeate across the collecting duct membrane because the Rh proteins are mutated. Or some of these patients may have abnormalities which have been described in mice. These proteins are called sulfatides. They actually are in the interstitium of the kidney and they bind ammonia. And when they're not working properly, you also can't get ammonia into the urine normally. So it's hypothesized that maybe some of these patients have sulfatide mutations. It's not well understood. So let's talk now about what occurs in a normal human when they get a metabolic acidosis to respond to the metabolic acidosis, and that will help us understand more definitively what's going on in distal RTA to answer the direct question, why do patients with distal RTA get a metabolic acidosis? Well, first we have to understand what occurs in a normal human. So if you have an extrarenal metabolic acidosis, which means a cause outside the kidney like lactic acidosis or ketoacidosis, whatever the cause, the kidney responds to that. And what it does is it tries to generate new bicarbonate above what it does normally, significantly above what it does normally to match the extrarenal proton load. And so you have much more glutamine taken up into the proximal tubule, much more bicarbonate generated, but as a byproduct of that, you get more ammonia produced, which ultimately gets excreted in the urine. So when we have a lactic acidosis, if we could measure the new renal bicarbonate generation, it would be 4 or 5 times what it is normally. We only get systemic metabolic acidosis when we have a lactic acidosis, when the proton load from the lactic acidosis exceeds the kidney's ability to generate new excessive amounts of bicarbonate. Only then does the bicarbonate in the blood start to fall. So that's something you have to realize. Initially, we don't get it because the kidney just recognizes it and increases its bicarbonate generation, so our blood bicarbonate stays at 25. Now, the second thing that happens is, in addition to this new excessive bicarbonate generation, is we get a change in the urine to renal vein ammonia partitioning. So instead of 60% of the ammonia going into the urine, we now increase that to 80%. So we get rid of a much greater fraction of the ammonia that is being made. And that, again, is very helpful because it frees up a greater percentage of the bicarbonate that's being made from being turned into urea, which would be futile. It wouldn't matter that we're making all this excessive bicarbonate to match the lactic acidosis. If all this excessive bicarbonate was turned into urea, it would not get us anywhere. So that's helped by putting more of that ammonia into the urine. We also increase the amount of H2PO4- being made, so-called titratable acid, and we excrete more of that in the urine by enhancing our proximal tubule and collecting duct proton secretion processes. It turns out also that the liver responds by making less urea. So the ureagenesis in metabolic acidosis actually falls. And that allows the liver to consume less bicarbonate in the urea cycle. So not only is more bicarbonate being made, less bicarbonate is being wasted in the creation of urea. Now, it's these two processes which don't change normally in distal RTA. And that's the reason for the metabolic acidosis, which we'll show in a minute. So in distal RTA, we have a problem getting the 80% of the ammonia into the urine, and that's because we can't acidify the lumen. Now, remember what I said, that the acidification of the inside of this collecting duct is very important for lowering the NH3 concentration here to allow more and more NH3 to enter. It's the lowering of the NH3 here by conversion into NH4 that keeps this NH3 concentration low, thereby creating a gradient from the outside in for NH3 to continually enter. If you allow the NH3 to go up here to too great an extent, you just stop this process. Even though the Rh proteins are fine, you don't have the concentration gradient anymore for NH3 to enter. And so you don't have the same amount of total ammonia being excreted in the urine. And where does that ammonia go? Well, in a certain sense, the kidney only has one other exit route, and that's to go into the renal vein. So the problem with distal RTA is the kidney is making a lot more ammonia because it recognizes that it needs more bicarbonate to match the metabolic acidosis being created. But it doesn't go into the urine, and so the excess ammonia goes into the renal vein and gets consumed in the formation of urea. So we're using up a lot more systemic bicarbonate than we should be in the formation of urea. And the other reason is we're not secreting protons in the collecting duct normally, when either we have a vacuolar proton pump problem or an AE1 problem, and therefore we're not creating as much H2PO4 2-, so our titratable acid excretion goes down. The proximal tubule is still creating at 60%, but we lose the 40% of the collecting duct component, and so that's the second reason why our new bicarbonate generation is not what it should be. So sometimes you'll see in the literature to diagnose distal RTA, or as a manifestation of it, you'll try to see how much ammonia there is in the urine. So there is less ammonia in the urine, and so people historically came up with measuring the urine anion gap as an indirect assessment of what the urine ammonia is. But it turns out that's basically useless. You get numbers that are all over the map, and that should not be something you recognize as a useful way of assessing the ammonia concentration. Another way is to measure the so-called urine osmolal gap, which you calculate by taking 2 times the urine sodium plus potassium plus the glucose in the urine over 18 plus the urea in the urine divided by 2.4, and you subtract from that the measured osmolality, and then you divide that by 2 to get the urine ammonia. That's a little more accurate, but the best way is to measure it directly. The problem is it's a nightmare trying to get the clinical lab to measure the ammonia in the urine in most hospitals, and still it's hard to believe in 2021 that's a big issue. So it's hard to get. But the other important point, which is basically totally unrecognized in the literature, is, and it's now in at least 5 different papers, is that not only is the urine ammonia low in distal RTA, but the blood ammonia is increased. And you just won't find this in any papers. You have to go to these separate case reports. And it makes perfect sense. The reason the blood ammonia is increased is we have an abnormality in, as I said, renal ammonia partitioning, where we are unable to get the ammonia into the urine, and that ammonia just leaves the kidney and goes into the blood. And in the presence of decreased hepatic ureagenesis, because the patients have metabolic acidosis, that blood ammonia can go up. And it's just something to consider. If you have someone with an elevated urine pH and their urine ammonia is low and their blood ammonia is high, that's distal RTA. There's nothing else that can do that. So that's something that's not recognized, that the blood ammonia to urine ammonia ratio is actually higher than normal. You won't find that anywhere in any textbooks or anywhere in the literature, but it is a fact. Now let's get down to some of the other phenomenology which we haven't discussed, and that's calcium. We mentioned a number of times that patients can have nephrocalcinosis, they can have hypercalciuria, they can have calcium phosphate stones. Why is that? Well, first, if you look at the histology of these kidneys, and that goes back to that original paper I was talking to you about when they talked about calcium infarction in the infants. These patients in the terminal portions of the collecting duct have calcium in the kidney that you see here throughout the parenchyma. It was also known, studies by Soriano in the 80s, that if you can vary the plasma bicarbonate, you get this very nice linear correlation with the amount of calcium coming out in the urine, that as the plasma bicarbonate decreases, there's more and more calcium coming out. And that simplistically made people think, well, it must be coming from bone. As we acidify the blood, we're just leaching more calcium from bone. We'll talk about why that's not true in just a minute. As far as the therapy for this, people give K citrate. As you give citrate, you increase the solubility of calcium in the urine and help decrease the amount of calcium phosphate stones formed. You give K because they're hypokalemic. The problem is when you give the K citrate, you start alkalinizing the urine. And as you alkalinize the urine, the calcium phosphate, as I mentioned in the cornea before, can come out of solution. So the approach is to give the K citrate. If the urine pH starts going above 6.5, then you try to give thiazides and stop the, you don't go any higher in the K citrate. Try to get rid of the hypercalciuria with thiazides if you can. And the thiazides might also help also, because remember the thiazides cause a metabolic alkalosis, so they might help with the pH, but the thiazides may decrease your potassium in your blood, so it's sort of a plus minus. So this is actually now felt to be the mechanism of the hypercalciuria. It's the role of this TRP channel, one of the TRP channels, the TRPV5, a channel that's now shown to be in a portion of the nephron called the DC2, distal convoluted tubule, the second portion, and also the portion right after it called the connecting tubule. So, you know, clinically we simplistically say proximal and distal, but that's something a medical student, you know, should be doing. As a renal fellow, you should know all the parts of the nephron, because without knowing that, you're not going to know anatomically where the transporters are that are involved with acid-base balance, and really the rest of the transport phenomenology in the nephron. So this protein is actually a channel. It transports calcium. It's on the luminal membrane of the DCT2 and the CNT. And the interesting thing about it is it's, number one, pH sensitive. If you lower the pH of the lumen or you lower the pH of the cell, this thing shuts off. Also, its expression is pH dependent. So here's an animal showing the normal expression. If you acidify the animal with an ammonium chloride, you decrease the expression of this protein. So not only is its transport pH dependent, the amount of protein in the cell is also pH dependent. And it's shown, the effect of not having it is shown here in this panel here. Actually, this panel, we'll go through this study first. So this is a wild type animal, and this is looking at the amount of calcium in the urine in controls, and then after acidifying the blood, either by giving ammonium chloride or giving Diamox. And what you see here is that in normal animals, you get this increase in excretion in the urine. Now, what happens if you don't have it? And again, historically, people would say, oh, this is just coming from bone. But look what happens in the knockout mouse, lacking this protein. Here's the wild type. And now look at what happens. First of all, in the wild type, there's a ton more calcium coming out in the urine. This is 300 micromoles per day compared to 25 micromoles a day. So the animals, in the absence of this protein, have significant hypercalciuria. So right away, you know this protein is important for calcium transport in the nephron. But the other important point is, after having given ammonium chloride or acetazolamide, there's no change in urine calcium excretion. So these animals do not have an increase in calcium excretion when their blood becomes acidic. So if it was bone, you would expect it to go up. So this is telling you that, at least from these experiments, that the response to acidifying the blood is due to this transporter. And when it doesn't function normally, you don't get a change in your urine calcium excretion. So this protein is now felt to be what's involved in distal RTA, that because of the acidification of the, potentially of the cell itself, you're not getting as much protein expressed, plus you shut it off. And that's why the patients get hypercalciuria. The nephrocalcinosis is not well understood. And that's also potentially why they get calcium phosphate stones. Now notice, patients with distal RTA do not get calcium oxalate stones, which is the typical stone makeup when it's idiopathic. In both distal RTA and, it turns out, in Bartter syndrome, they tend to get calcium phosphate stones. Now, the other thing that happens is it's felt to happen, and this is a hypothesis, but in the collecting duct cells, particularly the principal cell and the intermedullary collecting duct cells, there's a calcium sensing receptor that we know of on the parathyroid that we, block with Sensipar. Anyway, the calcium sensing receptor is also in these cells, and it's felt that when they have hypercalciuria, the calcium binds to this receptor, but there's an effect on water transport, and it turns out that aquaporin 2 cannot insert in the membrane normally. So these patients get, you can think of it like a nephrogenic DI in addition, and that's felt to be the mechanism of their polyuria, patients with distal RTA. It's the aquaporin 2 cannot insert in the membrane, and the water permeability of these cells is lower than it should be. There's another phenomenon which people think might be going on, and that is when the calcium sensing receptor sees calcium, when there's too much of it, you stimulate acidification of the urine, and that helps keep the calcium in solution by keeping the pH here low. But if you have calcium here and you have distal RTA where this is blocked, you lose the ability to keep the calcium phosphate in solution, and the calcium phosphate can then come out of solution as a stone. Now, what about the hypokalemia? These patients have severe hypokalemia, and the bottom line is there's many hypotheses, but no one understands the mechanism. So, and all parts of the nephron have been hypothesized. So people hypothesize the proximal tubule is involved, where the metabolic acidosis decreases paracellular, which means between the cells, and transcellular sodium chloride transport, and also passive potassium absorption. Again, one hypothesis. The thick ascending limb has been invoked, where ROM-K, which is the potassium channel in the thick ascending limb cells, is felt to potentially be inhibited. Again, this channel is mutated in one of the Bartter syndrome genes that are involved. But anyway, it's felt to be potentially involved in these patients. Again, a hypothesis. And the collecting duct has been invoked, where one has increased sodium delivery, luminal flow, and aldosterone enhances K secretion. But again, no one knows what part of the nephron is involved and why. But these patients can have severe hypokalemia with Ks of 1.7, 1.8, that kind of thing. And then lastly, to diagnose distal RTA, historically, people used to use ammonium chloride, but it causes nausea. It's sort of hard to do for the patient. So what has evolved is this other test, which is a Lasix Florinef combined test, where you give 40 milligrams of Lasix and Florinef, and the urine pH at about 4 hours after giving this should go down to under 5.3 in normals. If it doesn't, then you have a urine acidification problem. And if you're measuring ammonia, the ammonia excretion should go up above 33 micromoles a minute, roughly, by the second hour. So if you see either of those things occurring, you have a problem with acidification of the collecting duct. Now, yes, it could be a problem with ammonia transfer if you have RH, protein problems, that kind of thing. But assuming the ammonia excretion is sensing the pH, in the absence of lowering the pH, the ammonia excretion will also be low for the reasons I talked about. The other way to look at it is not to assess the pH or ammonia, but to assess something that's a little more indirect, and that's the PCO2 in the urine, so the partial pressure of carbon dioxide. In a normal person, if you give enough bicarbonate to flood the collecting duct, and typically we give this solution at 4 mils per kilo per hour, you'll get a ton of bicarbonate that escapes the proximal tubule into the collecting duct lumen. And in the presence of normal proton secretion, the protons won't bind ammonia, they'll bind the bicarbonate, which they typically don't do because there's really little bicarbonate in the collecting duct lumen. But if you force the system by giving so much bicarbonate that it gets into the urine, collecting duct urine, you will actually have protons binding to bicarbonate to make ultimately carbon dioxide. And it turns out the carbon dioxide stays in the lumen. It doesn't leak back into the blood, and it gets into the ureters and into the bladder through the urethra, and you'll excrete it in the urine. And a typical person will generate a PCO2 in the urine that's above approximately 30 millimeters of mercury more than blood. So if you have 40 in your blood, let's say, it'll go up to about 70. And if you see that, you know indirectly that the proton secretion must have been normal. Whereas someone with distal Rta, Halpern showed in 1974, a number of years ago, that their PCO2s in their urine hardly changes. And the thought is they have abnormal proton secretion, so they can't generate carbon dioxide. Now, obviously, this is a bit harder to do and is rarely done in the hospital because you have to give the bicarbonate, you have to get the urine bicarbonate high enough, you have to send the blood for or send the urine for gases, and the clinical lab doesn't know what you're talking about. You have to collect the urine pretty quickly and not let it sit so that the carbon dioxide doesn't leave. So it's technically more of a hassle. So this is by far the easiest test to do to see whether someone can acidify their urine normally. And with that, I'll stop. So I'd be glad to take any questions anybody has on anything I've said. Any questions at all?
Thank you, Dr. Kurtz.
Okay, well, if not, I'll stop there. And if anyone has any questions after, please feel free to email me or contact me. I'd be glad to go over anything that requires additional discussion.
Thanks, Dr. Kurtz.
Okay, thank you.